Welcome to our podcast, Psychiatric Services from Pages to Practice. We had a 1-month hiatus due to the COVID-19 pandemic, and we're back. We're back
full
to discuss.
Force.
Yes, okay. So as our listeners know, in this podcast, we highlight new research or columns, articles published this past month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services and recovering coronavirus sufferer. And I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hey, Lisa. We're glad to have you back.
Yeah, well, I'm very glad to be back. And actually, before we start, I would like to actually sort of take a moment of podcast silence to really acknowledge the pain and the suffering and the death that many, many have experienced. Both of us, Josh being in New York, certainly don't have many degrees of separation from people who've lost their lives. So we'll take a moment. It's been a tough time. Very tough time. And now, though, we're looking forward, we're moving forward, and the podcast, we hope, will contribute to people's knowledge and understanding and ability to help. And in that spirit, we are discussing an article today that you'll hear more about. It's from the Psychiatric Services Policy Advisory Group. And I wanted to say that this article, like many, many others on the COVID-19 pandemic, was put online at the time of acceptance, not waiting for the publication process. So I want to refer everybody to this website, ps.psychiatryonline.org. I'll repeat it at the end of our podcast as well, where you can go right now and see articles that are very current, that are very timely, that have literally just been accepted. You will also see an editor's choice collection on telepsychiatry, as well as our published contributions. So we're looking forward to today's podcast.
Should be a good conversation. Today, we are very lucky to have Matt Goldman with us. He is a UCSF Public Psychiatry Fellow and also a clinical instructor at the UCSF Department of Psychiatry. And he's here to talk with us on his recent paper, Mental Health Policy in the Era of COVID-19, which he wrote with many co-authors. So, Matt, welcome to the podcast. Thanks for joining us and sitting through about 45 minutes of technical difficulties.
No problem. It's a pleasure to be here. Big fan of the show.
All right. Yes. Great. We got a fan. So before we dive into the paper, maybe you could tell us a little bit about what some of your interests are, kind of what some of your pre-COVID interests and responsibilities and work was centered around, how you kind of shifted into more COVID-related work.
Yeah, sure. So as you mentioned, I'm a public psychiatry fellow at UCSF. So I am currently working at a community mental health center in San Francisco and also working with San Francisco's mobile crisis team. And my interests in the last year or so have really focused on suicide prevention best practices in mobile crisis. And that's something that I'm working towards developing a research career around. But I, like everyone, found that everything changed just a few months ago with the arrival of the COVID-19 pandemic. And it really precipitated a need for rapid adjustment. So I now am providing all of my care through telephone-only services. That's been a huge change. My outpatient clinic and also the post-crisis follow-up appointments that I see patients through, those are all now on the phone. So I've needed to adapt to that new telehealth world. But also, I, for a long time, have been really interested in mental health policy. So this paper is actually the first product of a group that I and Lisa have gotten to work on called the Psychiatric Services Policy Advisory Group. And this is a group that came from some conversations that Lisa and I had a few months ago around the importance of mental health policy in psychiatric services. We know now that policy makers are hungry for evidence-based practices to inform the types of policies that are being put in place. And so we thought that given that psychiatric services is such an important journal and such an important source of the evidence that informs that policy making, that it would make sense from the academic side, from the publication side, to think critically about what are the ways that we can frame our evidence to be most useful to those policymakers, given the huge influence that policies have on how mental health services actually end up being provided. And so from that conversation, we had the thought to create this policy advisory group, which is comprised of experts in the field. It's been amazing getting to know and work with some of these members.
So the paper is organized in a way that's very easy to follow. And one of the things that you do is, when I hear about policy, it's often, it's a little bit overwhelming, right? Like what exactly
is policy? Right?
What is policy? So, that'll be maybe our next podcast, which we can all co-host together. What is policy? But I think you do a really nice job of framing that question and then applying it to COVID-19. So what's the kind of framework that you use, at least in this paper, to think about what policy is and how to think about it?
Yeah, so as a group, as we were meeting, one of our broader objectives was to try to convey what is mental health policy to that broader question. And given that we were meeting for the first time as COVID-19 was hitting, we decided that we might as well try to address that question in a real-world setting, given that COVID-19 has precipitated so many huge policy changes. And by organizing some of those changes that we've seen in these different categories, we can then help answer that question of what is mental health policy. So we divided it into 5 different sections. We, in the paper, talk about legislation, regulations, financing, accountability, and then workforce development. So to go through each of these briefly, legislation is lawmaking. That's the legal mechanism where, in the case of the federal government, it's the U.S. Congress, or at state and local levels, there's various different types of representative bodies that pass laws or ordinances. And there have been some really important laws passed in the setting of COVID-19. So the most important one is the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act, which was a $2 trillion stimulus package that had a lot of important provisions related to mental health. So among those, there's money that goes to SAMHSA, there's money that goes to expanding the CCBHC program, Certified Community Behavioral Health Clinics, the famous 42 CFR Part 2, which is about sharing of treatment information for people with substance use disorders, that was modified in the CARES Act. So some really important laws were passed in this bill, and we know that Congress is going to continue working on bills. And so for advocates, that's a really important target to think about. How do we affect this lawmaking process through activities like advocating and lobbying to our elected representatives?
So that's the legislative piece of the framework, and then there's a regulatory piece. Was the next one that you mentioned. So what's kind of the difference between the legislative aspects and the regulatory aspects, and what's been going on with COVID in terms of regulations?
Yeah, so legislation is really the law. That's the legal code. That's the statute. The regulations are what come at the agency level as different government bodies are actually implementing the law itself. So regulations can include a wide range of activities, things like reimbursement rules, patient eligibility for different programs, accreditation requirements, all kinds of things. And so some of the really important regulations that changed to make mental health care more feasible to provide during the COVID-19 crisis have been things focused on, how do we actually get these services to people as we're having to respect social distancing, as we're having to reduce face-to-face contact. Some of those regulations have focused on things like being able to give methadone through opioid treatment programs for longer time periods. So rather than daily distributions, they're able to dispense 14 or even 28-day supplies for patients who are viewed as stable.
This is such a big deal. It's so important.
Yeah. Because, to have patients coming in every single day and potentially exposing themselves and staff with face-to-face contact is increasing risk due to the virus. Also, a huge change is related to clozapine. So, of course, we know one of the main challenges of prescribing clozapine is the requirement of frequent blood monitoring, blood tests to check the absolute neutrophil count. And the Food and Drug Administration put out a guidance that they would not prevent pharmacies from dispensing medications that require REMS programs, or risk evaluation and mitigation strategy type programs like clozapine, that they would not have those requirements be enforced. Basically saying that people who are on clozapine don't need to keep exposing themselves and staff to get those weekly blood tests, so long as they've recently had normal ANC levels, because that risk outweighs the benefit. There's even some studies that showed that people who are on clozapine might be especially high risk of suffering some of the dangerous effects of COVID. And so it was important to protect those patients. And then other regulations like easing telehealth rules, making it so that we don't need to use HIPAA-compliant platforms for telehealth necessarily, that those rules wouldn't be enforced. A lot of important regulations at that level have made a huge impact on care.
Articulating these changes, I mean, these have had just an enormous impact. We would not be able to do near what we're doing now without these regulatory changes, I think.
Absolutely. As somebody who's relatively young in this world of mental health policy, I've got to say it's been very eye-opening to see just how quickly things can change. We, in a way, think of these regulations as these hard rules that are set in stone, and we have to fight tooth and nail to make change happen. And then all of a sudden, in a couple months, the changes in these telehealth regulations and others have completely transformed the way that we provide care. Yeah.
It's also been really interesting just to realize the scale of changes that needed to happen and have happened so rapidly. I mean, I think from like a lay public point of view, it's like, oh yeah, you can, we'll just start making phone calls instead of coming in to visits. But just the kind of amount of things that need to change to make that happen, and maybe you'll get into this with some of the other dimensions of policy, it's been really striking. Or like, to keep clinics viable, the amount of regulations that need to be adjusted in order to make that happen, and the rapidity with which that's occurred has been really just shocking to me.
Absolutely. I think this is a lesson that when there's a will, there's a way, and these changes are possible. The right environment needs to be in place. And so this is in the setting of a crisis, but it is a good lesson that these are human inventions that can change in the future too.
Yeah. And so Matt, maybe you could just touch briefly on the other three dimensions, which have also had really massive changes in the past couple months.
Sure, absolutely. So the next type of change that we talked about is financing. So, financing is often changed through legislation and regulations, but those are government financing actions. There are other type of financing changes that can happen in the private sector, like with insurance companies. And there have been really important changes there in terms of incentivizing care, especially, again, related to telehealth. Previously, telehealth reimbursement rates had been much lower than in-person visits, but now as part of those regulatory changes, telehealth is largely being reimbursed at equal rates to in-person visits, and now more recently even by telephone. That's true for Medicare, and for most states have changed their Medicaid plans to have equal reimbursement rates. Insurance companies that are privately owned and operated are a little slower to adopt that, but there certainly has been an effort to really move insurance companies across different payer types to be able to cover this type of care.
And then the last two dimensions were accountability and workforce.
Yeah, so accountability is an important policy lever in that we all hear now about quality measurement, about value-based payments, about the importance of accreditation and licensure, the different mechanisms that are out there to make providers of care accountable. Those are all opportunities for policy change as well. And so the example that we provided was that the merit-based incentive payment system, or the MIPS program, is an important value-based payment model that is launched by CMS. They have delayed the reporting requirements for that program during the COVID-19 crisis, just as an example that accountability itself can shift depending on the needs of providers. And then lastly, as you mentioned, workforce development. So developing an adequate workforce, of course, is so important to be able to provide mental health services to the populations that we're serving. And that's been challenged during the stay-at-home orders, during shelter-in-place orders, during the need to reduce face-to-face contact. So one important example is states have temporarily waived state licensing and renewal requirements, which has been kept close track of by the Federation of State Medical Boards. Also, things like having providers enroll with Medicare or Medicaid with insurance plans, having providers be able to prescribe across state lines, including for controlled substances, having providers, and this is specific to nurse practitioners or physician assistants, not as closely being required to be supervised by physicians. These are all changes that are really focused on making sure that the workforce is able to maximize its capacity while we're otherwise strained by the constraints of the pandemic.
I was really struck by the increased flexibility regarding state licensing and, the ability to see your patient who might not be geographically, who may be staying with family or who may be out of, have moved temporarily. Which I thought was really, really important. Obviously, in a bigger state with less geographic mobility, it would be less important than in New York, which is, where this happens quite a bit.
Yeah, there's two factors that play into that. One is the state licensing, and the other is being able to be reimbursed for that care. And so that's where that's sort of an intersection of the telehealth rules changing so that you're able to provide telehealth care to somebody who's in a different state, and a different set of licensing rules changing so that you're legally allowed to provide that care, and a different set of FDA-related or DEA-related prescribing rules allowing you to prescribe for that person in a different state. So it's a really complex set of rules that need to be addressed to be able to adjust that care. But just as you said, it's so important.
Is this all policy, Matt? Is this what we mean by policy?
I think so. Absolutely.
Gee whiz.
Absolutely. These extremely complex sets of rules and regulations and laws, this exists around us and impacts the way that we provide care every single day. And it's not necessarily always that clear, but I feel like now in this era of COVID, we're all seeing just how important these rules are and have seen just how adaptive they can be in the right circumstances.
So we can think of COVID as a tutorial in policy.
Absolutely.
And Matt, before we wrap up with the paper, I think it's important to mention the it seems to me like there's a couple kind of like umbrella issues as well that sort of span all of these different dimensions of policy. Could you just talk a little bit about those?
Yeah, definitely. So as we were thinking about these different types of policy changes, we also wanted to think about specific use cases. What are specific issues that have broad consensus within the field that are important targets for policy change through these different mechanisms? And so the examples that we came up with were social determinants of health, innovative technologies, and then research and evaluation. Social determinants of health, we know how important it is to consider social determinants as we're thinking about new policies. There are so many unintended consequences from policies that really disproportionately affect vulnerable populations in negative, problematic ways. And COVID-19, as we now unfortunately know, is very much an example of that. COVID-19 disproportionately affects people of color. It affects people who are in congregate settings, like those who are incarcerated. It affects homeless populations more so, immigrant populations more so. The reality that COVID-19 is so much of an additional challenge for groups like those and others means that as we're thinking about policies, we have to be really careful to make sure that those policies apply broadly and don't exacerbate underlying disparities. That's this idea that we had where COVID-19 in a way precipitates these acute on chronic disparities, where long-term existing disparities are now exacerbated by this acute situation. And then the other two examples, so innovative technologies, I think that's quite clear how, especially in the realm of telehealth, we need new technologies to be able to ensure that care is being delivered. And so policies that facilitate that kind of technological change are really important. And then finally, to the point of research and evaluation, there's a lot of excitement. Often you'll hear people saying, telehealth has been so much better than we thought it would be. We want this to stick around. We want to make sure that these changes are continued. I think that may well make sense, but we also want to be careful because first, before we decide which policies should be kept in place or not, ideally we would have some amount of research or evaluation to be able to measure how outcomes actually change as a result of these new policies. That's going to be really hard to study because the data is all going to be influenced by so many different factors. But I think it behooves us as well as we can to be critical about what of these policy changes should be sustained or maybe shouldn't be sustained based on the information that we have available.
But what I like about the article, Matt, is that it's broad in scope, and it introduces people to sort of the concepts and the multidimensionality of policy, so that you can then, in your own research, in what are the updated policies, you can see what to look for, and I think that's a unique aspect of this paper.
Yep, absolutely.
All right. Well, Matt, thank you so much both for the work you're doing and for joining us here on the podcast. And we hope you stay safe and healthy out there on the West Coast.
Thanks so much. This has been a lot of fun.
Wow. This is just a lot going on. And I personally really appreciate the work of Matt Goldman and the Psych Services Policy Advisory Group, and really helping us to wrap our heads around what has happened. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed today. And as I mentioned earlier, all of these articles that the journal has just accepted and, of course, has published, so you can really get the timely information on the pandemic. We also, of course, always welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berzin.
Thank you so much for listening. We'll talk to you next time.